And we could start our video at any point, and I don't know if we have our. And so for today, we have one of our faculty members who will be presenting to us. So thank you, Dr. Gendelberg. And then for an introduction, I'll turn it over to Dr. Bervin.
Well, thank you, Drew. Talkalicious is attractive. So it's my pleasure to introduce my friend and colleague, David Gendelberg. David's going to be giving grand rounds today on a topic that we both feel passionately about, and much of our work together has been on disparities of healthcare and social determinants of health. David and I share a lot in background. We're both Jersey boys in some ways, although David was spent time in high school in Israel. And he came back to Jersey. He was at Rutgers as an undergraduate and as a medical student, went on to Penn State for his residency. Then he's done advanced training in spine surgery, both at Harborview, and then he did some further work at Cedars using looking at minimally invasive spine surgery. He was actually on the faculty at Harborview when Ash was doing his fellowship there. David did further training in trauma here, and he's been on our faculty now. This is the second year, and just doing some terrific work with regard to spine surgery, as well as care for the underserved. And David's got a real passion. He's been involved in many different healthcare systems between Israel and the US, and private systems, out-of-network systems. And David understands some of the good, the bad, and the ugly of our healthcare system. And he's got a real passion about issues of disparities in healthcare, inequalities of access. And today he's going to talk about challenges in delivering healthcare to the underserved. So thank you, David.
Thank you, Sig. So I'll be talking about the challenges in delivering spine care to the underserved. Are we properly treating this population? So I have no relevant disclosures. Here you can see an outline of my talk. Now, I won't be discussing the overall concept of universal healthcare versus fee-for-service, which is a large topic in itself. The goal of this talk is to discuss the challenges we face caring for this complex population within the current healthcare systems and how we are addressing it. And so I'll start out by introducing you to two patients that will kind of accompany us during the talk. The first patient is a 56-year-old male immigrant with long-standing bilateral L5 radiculopathy, but tolerable back pain. He's failed conservative management, he has stable spondy, and he works as a cook. The second patient is a 42-year-old African-American male with bilateral radiculopathy, no neck pain. He's failed conservative management. His facets are relatively preserved, and he works as a janitor, living paycheck to paycheck. And so underserved populations in healthcare are groups of people who experience barriers to accessing healthcare services and face disparities in healthcare outcomes. In the US, there are approximately 95 million people who live in underserved communities, about 28% of the total US population. These communities often lack adequate healthcare resources, and delivering care to these populations could be rather challenging. And so these populations may include low-income individuals who face financial barriers, uninsured or underinsured, who have the inability to take time off work to seek care. They are populations who live in rural communities and healthcare deserts who have a scarcity of resources and providers in their regions. Racial and ethnic minorities, the elderly who have chronic health conditions, are socially isolated, as well as have mobility issues, individuals with disabilities, people with unstable housing, and overall, many of the underserved tend to have more labor-intensive occupations. And as you can see by this map of the United States, it's really affects a large portion of our population. So medically underserved areas, medically underserved populations, and that is a subset of the medically underserved populations. And so in California, an estimated 11.2 million people live in an area that has a shortage of primary care providers. Approximately 150,000 people are experiencing homelessness and in need of housing, health, and social services. And those who live on the streets die an average of 20 years earlier than the people who are housed. Furthermore, we know that the social determinants of health account for about 80% of health outcomes. Often these social determinants go hand in hand. There's a certain intersectionality between them. Some are modifiable and some are not. For example, Someone with unstable housing may also have an unstable income as well as food instability. We need to be aware of these social determinants of health to help mitigate the effect they have on our patients and to help provide better care to these populations to overcome their disparities. One of the major constraints that the population faces are financial constraints. While direct costs may be cumbersome, there are also a significant amount of indirect costs, such as the cost of missing work or other important obligations, costs of transportation to and from the appointment, childcare, as well as other out-of-pocket expenses. A travesty in our healthcare system is personal bankruptcy. Medical bills are the #1 reason for personal bankruptcy in the United States. And over 700,000 people per year declare bankruptcy for medical bills. This is unique to our out-of-fee service system and does not necessarily exist in other countries. The burden on the poor, especially the working poor who aren't Medicaid eligible, is exceptional. And so the patients who have inadequate coverage will often delay seeking care, get care that doesn't fit their needs. They may get a late diagnosis for their disease, get less care overall, and as well, may go into debt. This is a huge problem. And so on top of the financial barriers, they also have a transportation barrier. They have, on average, they have a lack of reliable transportation, whether it be private or public. They often have to use public transportation to get to their appointment, which prolongs the amount of time that they need to travel. They may need to ask a ride from a friend or family member, which in itself ends up costing that driver time and money. And it may result in delay of care or lack of follow-up just because they can't make it to their appointment in time. It may necessitate that they may need to leave their job earlier to make sure they make it to their appointment on time, which may lead to longer time of missed work. Or they may arrive for their appointment early or late, which disrupts the flow of clinic, affecting all the other patients in the clinic and taking up their time. And on top of that, the elderly and disabled patients may have physical difficulty with getting to their appointments. And all this is without taking into account the fact that the underserved may have lower education, may have lower health literacy, which are both vital for navigating our complex health system. According to this 2004 report by the Institute of Medicine, health literacy is defined as the ability which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions and follow instructions for treatment. Limited health literacy is associated with poorer health outcomes, higher rates of hospitalization, and use of emergency services. Annual healthcare costs for those with low literacy skills are 4 times higher than those with higher literacy skills. According to the US Department of Education Adult Literacy Study, 14% of adults fell below basic health literacy. A higher percentage of African Americans and Hispanics had fallen below the health literacy rate as compared to other racial and ethnic groups. Overall, Hispanics had lower average health literacy compared with all other groups. Other populations of adults who fall below the basic health literacy category were people who didn't graduate high school, the elderly, people who did not speak English before starting school, as well as adults living below the poverty level. And if their social determinants of health status wasn't enough to put the underserved at a disadvantage, there are also a variety of systemic constraints working against them. Resources available to the underserved may be more limited. There may be more limited provider availability, longer wait times for appointments as well as for tests. And so in a Merritt-Hawkins survey comparing Medicaid acceptance rates among specialties in 15 metropolitan areas, orthopedic surgery was consistently under 50% acceptance. Now you could see we're better than some of the other specialties, but if you look at the numbers over here, between 2004 to 2017, we haven't really changed. Just because we're better than some of the other specialties does not make that adequate. In this study over here, they sought to see whether orthopedic practices provide varying access to orthopedic care for simulated patients with Medicaid insurance versus private insurance in a blinded survey. Furthermore, they wanted to see whether access to orthopedic care in the adult population varied between private and academic practices. And so what they did, it was actually pretty interesting. They called practices as fictitious patients with ankle fractures to make an appointment. Each practice got 2 phone calls, one where the fictitious patient had commercial insurance and one where the fictitious patients had Medicaid insurance. And they called both academic as well as private institutions. And so what they found was that there was a 97% acceptance rate among practices for patients who had commercial insurance versus 47% for those with Medicaid. And when looking at whether they could get an appointment within 2 weeks, it went down to 89% for the commercial insurance and only 36% for the Medicaid population. And looking further, teasing out between private and academic practices, they found that academic institutions accept a larger amount of those on Medicaid. And so academic centers bear most of the burden. And so that creates longer wait time at our institutions, makes us less available for complex pathology, and academic centers are effectively subsidizing private practices when it comes to this population. Oftentimes, it's claimed that the reason Medicaid patients aren't accepted is because of their complex pathology or medical comorbidities. So in this study over here, they wanted to examine the relationship between health insurance status and access to spine care among patients. So they looked at a group of spine patients who were treated surgically for similar pathologies of limited complexity, who also had limited comorbidities, and divided them into groups that were covered by Medicaid versus private insurance. And so what they found was that travel time and distance for the private versus the Medicaid was that the private patient traveled on average 14 miles in 24 minutes, and the Medicaid patients traveled 51 miles with an average of 73 minutes per visit. And so one of the arguments for the longer travel distance and time is because oftentimes the underserved may live in healthcare deserts or may live in more rural areas where there aren't as many providers available, forcing them to commute further. However, they found that the average privately insured patient passed 2.3 fellowship-trained spine surgeons on their way to the academic center versus the Medicaid patients passed on average 5.5 surgeons on the way to the academic center. So they're not necessarily living in a healthcare desert. This is problematic. In this study, looking at the utilization of a tertiary hand surgery referral center and looking at insurance status and access, they evaluated almost 4,000 patients with orthopedic hand problems. They looked at the relationship of insurance status, clinical complexity, and distance travel to appointments. They evaluated barriers to accessing care through a survey that was distributed among the local primary care providers. And then they analyzed patient arrival rates and operative rates in regards to insurance status. And what they found was that Medicaid patients were significantly less likely to present with problems of simple complexity. Perhaps it's due to delay of care, perhaps they weren't able to take time off for simple complexity. Primary care physicians reported that 62% of local surgeons accepted patients with Medicaid versus 100% who accepted those with private insurance. 43% of PCPs reported that the denied underinsured patients were unable to drive to the tertiary center due to limited personal resources. And in addition, the Medicaid insurance group also had significantly more no-shows, which isn't really surprising considering everything else we see over here. And so let's take a step back and summarize where we're at. So getting care as the underserved, you face many barriers. So first off, you have this monstrosity of a system that you need to try to understand. It's a very complex system. You may not have the health literacy to fully understand it, maybe because English isn't your first language, maybe educational status, or a variety of other reasons. So once you've kind of navigated the system, now you need to figure out how you're going to get to your appointment. You need to either bear the direct cost, if you have a car, of driving to the appointment, public transportation, maybe getting a friend to pick you up, which is a burden on them. And this all results in lost time and lost work. Many of the underserved work hourly jobs and aren't on a full salary. So if they miss work, that's less income for them. And then on top of that, finding a physician that will accept them. So they need to drive further, which is even more lost time, more transportation costs. And all this results in delay in care. And it's not just to see the physician. If a patient comes and sees me and I need to order an MRI, all these burdens and all these delays apply to getting the MRI and then getting the follow-up appointment with me and so on. It all adds up. And on top of that, there are other costs. Versus someone who's on salary, insured, and not on an underserved population, higher likelihood of having a car. If I'm sitting up in my office, in my desk job, I just need to look at the travel time, go down to my car, drive to the appointment. There's going to be a shorter wait time because there's less congestion to see that particular physician. I have a better knowledge of the system. I'm able to make up my work later in the evening. And overall, I just have more options. And so perhaps having a universal healthcare system would help address these disparities. But unfortunately, that's not the system we live in today. And so when considering surgical candidates, many factors need to be taken into consideration. Those include patients' medical comorbidities, their aftercare, their social support, the risk of complications after surgery, their compliance. They have more laborsome jobs on average, so it's more difficult for them to take time off of work. And clinic follow-up. And so coming back to the social determinants of health, we see that our underserved population's health outcomes are affected by their social determinants of health. Therefore, this population on average will also have a worse health status, increased morbidity, more functional limitations, all of which make them a more complicated surgical candidate, which will require more pre-op optimization, and they're at risk for having more post-operative complications and difficulty following rehabilitation protocols. In this study, looking at the 90-day return to the emergency room and readmission after elective spine surgery, over 5,000 patients were analyzed, and what they found was that ER visits were more common in patients from zip codes with poor socioeconomic factors, areas where no outpatient facility associated with the institution was located within a 10-mile radius, as well as African American race. Of those admitted, IND was the most common reason for admission. So they're getting infected. On top of that, there are a variety of medical reasons up here, whether it's COPD, cardiac stents, that also resulted in them being readmitted. In this study, looking to determine whether the payer status is related to complication rate after spine surgery, they evaluated about 1,500 patients who underwent spine surgery, and multivariate analysis found that Medicaid patients had a 1.68 odds ratio of having any adverse event when compared with a privately insured. And that's not just related directly to the surgery, but also medical complications. In this study, looking at the association between socioeconomic status and 30 and 90-day risk for infection after total hip arthroplasty, they found that living alone low educational achievement, low income, or low savings were associated with higher risks of infection within the first 30 and 90 days. And so the previous study was a registry study of over 100,000 patients. And so you could say there's variability between institutions. You could say variability between surgeons. And so in this article that was actually published in this institution over here, they compared early complications in hip and knee arthroplasties between a safety net hospital and a university setting. They found that in the safety net hospital, there was a lower percentage of index revision procedures in the safety net group, and all surgeries were performed by a single surgeon. And they found that early complications were more frequent in the safety net hospital. And on top of that, the underserved have a higher loss to follow-up rate. In this study evaluating follow-up disparities, they found that out of about 15,000 patients who were discharged, failure to follow-up was associated with low income, higher poverty, lower education, older age, as well as non-white race. And in this study here, they were looking for factors associated with trauma clinic follow-up. They found that out of 1,800 people discharged, patients with no insurance, interestingly, white race, patients with Medicaid and Medicare, and patients older than 35 had a higher likelihood of failure to making it to their 4-week post-op or 4-week follow-up appointment. And so going back to access to care. Many of these factors with the underserved are representative of a bigger systemic issue in our healthcare system. However, the reality is that they pose real-time challenges to providing care and make many surgeons hesitant to treat the underserved. These patients are medically more complex. There are many non-medical challenges. The patients are less likely to follow up, decrease compliance, and often poorer outcomes. They're truly challenging to care for. But despite this, these patients still need care. However, all these factors should be taken into consideration during the surgical decision-making process, which really raises the question of, once they do become surgical candidates, what surgery do we perform? As any attending here would tell you, the appropriate surgical decision-making is as important as the decision to perform surgery, as well as vice versa. And so when deciding on surgery, patient needs and compliance should play a key role in the decision-making. One of the considerations is when the patient could return to work, especially with patients who have more labor-intensive jobs and are living paycheck to paycheck. That's a huge consideration of their surgical decision-making. And so in this study, 56 surgeons who routinely perform spinal surgeries were asked to provide their personal time off restrictions for various activity levels. And in these tables, you could see that with increasing activity levels, the median return to work time increases. And here you could see that with increasing activities above light duty, the fusion group had longer return to work periods. And considering the fact that the underserved have more labor-intensive jobs, on average, undergoing a fusion would disproportionately affect them, as well as perhaps their compliance. I mean, I remember I performed a laminectomy on a patient, and all of a sudden he had to move a week and a half after surgery, and he fractured his pars, and 3 weeks later he was getting a fusion. And it was because he had an unstable housing situation. And so knowing all this, let's come back to our original patient. He has a physical job, stable spondy. Should we fuse him or should we decompress him? And so in this study in the New England Journal of Medicine, they evaluated patients 50 to 80 years old with stable degenerative spondylolisthesis. They compared patients who underwent a posterolateral instrumented fusion with the laminectomy versus those who underwent the laminectomy alone. And they looked at SF36 and ODIs at 2 years. And overall, the patients were followed for 4 years. And so what they found was that the SF36 only showed a significant difference at 2 years, even though it also shows a difference at 6 months, but then that goes away. I don't have a full explanation for that. But then with the ODI, there was only statistically significant difference at 4 years. They also found that the cumulative risk of reoperation was 34% in the decompression alone group and 14% in the fusion group. And therefore, they concluded that fusion is more beneficial than decompression alone. But only 45 out of the 66 patients followed up at 4 years. Socioeconomic factors were not recorded, and it's also unclear why those patients did not follow up. And so, does this paper represent the underserved? Our patient? Is the increased revision rate associated with laminectomy worth a sooner return to work for someone who's dependent on every paycheck for his livelihood, especially when the SF36 and the ODI were only different at 2 and 4 years? Maybe underserved populations have a higher revision rate. We don't know. Perhaps technology and different techniques could aid us in treating this population. And so coming back to our patient with cervical stenosis and bilateral radiculopathy with relatively preserved facet, obviously the question is at hand is whether you fuse this person with an ACDF or whether you give them a disc replacement. I mean, when you compare the two, disc replacements have better range of motion, potentially reduced risk of adjacent segment disease, shorter recovery time, faster return to work, less post-operative restrictions. However, they're also more technically demanding and there are pretty strict patient selection criteria. So in this study, comparing return to work rates and activity profiles between ACDFs and cervical arthroplasties, they performed this meta-analysis, and they found that in all the studies that cervical disc replacements had a sooner return to activity than ACDFs. Even though they both had good return to work rates and they were equivalent at 6 months, the cervical disc replacement group resumed work sooner. And so comparing ACDFs and arthroplasty, the arthroplasty group generally has greater range of motion, potentially decreased risk of adjacent segment disease, as well as faster recovery time and faster return to work. Perhaps for our janitor, a cervical arthroplasty would be more beneficial. Maybe with people who are that laborsome, they have a higher failure rate. Perhaps in the underserved, indications should be changed. We don't know. Now coming back to our L4, L5 spondy patient, assuming we are performing an interbody fusion, how should we perform it? Traditionally, an open TLIF was the treatment of choice, as it provides greater surgical exposure, allows for more thorough decompression, is a more established technique, and potentially lower costs. But it's also a larger incision, predisposing for wound issues and infections. Another option that has been developed in recent years is the MIS TLIF, which provides a smaller incision, faster recovery, less pain, reduced scarring, shorter hospital stays, and again, with the smaller incisions, potentially lower complication rates. In addition to TLIFs, lateral MIS techniques have also been introduced, which have minimal muscle disruption, good visualization, potentially faster recovery, potentially lower complication rates, shorter hospital stays, and larger grafts. And so here in this table, comparing the three, you could see the advantages of each procedure highlighted in green and disadvantages highlighted in red. And here summarizing over here for overall, open T-lifts, they're more prevalent, but the recovery is longer, potentially more pain, but they're also less costly. Versus the minimally invasive T-lifts and lateral interbodies, they're technically more demanding, but they may have a quicker recovery, less pain, but it also requires more capital investment by the hospital and is more costly overall. And most studies don't show any significant difference in long-term outcome between the three. However, is there a difference in the underserved? We don't know. Well, maybe we should go to the literature to see if it could help us. However, the literature could be problematic, as research protocols are often cumbersome for the underserved. Minimum follow-up criteria may exclude the underserved, and socioeconomic factors are often not mentioned. In this study out of JBJS, they wanted to look at the rates of reporting race, ethnicity, and socioeconomic status in studies published in Core and JBJS. And what they found was that out of all eligible articles, depending on the factor they evaluated, there was only a 10 to 35% reporting rate of those characteristics in their included patient population. And so they concluded that they were infrequently reported and analyzed in 2 of the top orthopedic journals. And this problem needs to be addressed. And now, while this is a good start to solving the problem, again, they only looked at the patients that were already included in the studies, but there are a lot of inherent design flaws that prevent the underserved from even being included in the studies. So, as all the residents to tell you, they all know the sports studies. They need to know its conclusion for the OITs, and they get asked about it all the time. This is one of the largest, most planned out studies in the spine world, to the point that they published a paper explaining the rationale behind how they designed the study. And so let's take a look at their inclusion and exclusion criteria. And what you could see is that exclusion criteria were patients not being available for follow-up or unable to complete the questionnaires, which were in English. But let's see what follow-up consisted of. 2 short-term follow-up appointments and 5 long-term follow-up appointments, 7 follow-up appointments at 6, 12, 24, 36, and 48 months. So follow-up for 4 years. Well, let's see what each one of these appointments consisted of. So 1-hour clinic visits with the nurse, in addition to the visit with the physician. Could you imagine the burden that that would have on the underserved population? And so, knowing everything we have learned today, how representative of the underserved do we think this study is? Unfortunately, this study isn't alone. But in consideration of time, I used it as an example of how even one of the most thought out and meticulous studies performed in the spine world is still vulnerable to the constraints of the current research system. Leading to the phenomenon where we're utilizing treatment algorithms to populations not represented by the studies. And so, is the 2-year follow-up demanded in many studies even necessary? In this study over here, where we're looking to evaluate the appropriate follow-up times after spine surgery, they found that the time to plateau recovery after surgery for lumbar disc herniations, stenosis, and spondylolisthesis were up to 12 months, and in some cases, even 3 months. On top of that, when looking at spondylolisthesis and spinal stenosis patients who underwent fusion versus decompression alone, they plateaued at 12 months as compared to 3 months. And so this further suggests that some of the minimum follow-up criteria may be overly aggressive and unnecessarily excluding the underserved from the literature. And so how are we addressing the problem over at the general? Well, we're trying to perform more minimally invasive techniques. We're trying to get the family and social support system involved in the patient's care so they understand what the patient's needs will be after surgery. We try to make sure that they'll have some kind of care and won't just be left alone. We try to manage the patient's expectations, be very clear with how long we expect them to be off of work. Personally, I even exaggerate a little bit because no one's ever complained when I remove restrictions sooner. I assess the patient's social conditions, housing, food stability, and I really try to understand the patient's needs. And we try to get in-person interpreters whenever we can to really try to overcome that communication barrier um, that often plagues us and makes it more complex to deliver care. And you really need to know your patient and tailor the treatment to them. And so I'll present a few cases right now. So here we had a 66-year-old female with back pain, claudication, and compensated cirrhosis. She doesn't speak English. She lives alone. She's unable to walk 1 block. And her son has limited ability to take off of work to take care of her. And so we performed an L4, L5 lateral interbody fusion on her. She was able to walk down the hall on post-op day 1. She was discharged on post-op day 3. Her pain has completely resolved and she currently walks 3 miles a day. Here we have a 52-year-old patient with longstanding back pain, no radiculopathy. She has 2-level spondylolisthesis over here. She works as a cashier and it's painful for her to stand. She helps care for her grandchildren. She's exhausted at conservative management. And so we performed an L4, L5, and L5S1 MIS TLIF on her. Her back pain hasn't gone away, but it's significantly improved and she's back to work. And here we have a 67-year-old female with radiculopathy and claudication, some back pain, but her leg pain bothers her more than her back. And at the age of 67, she's starting a new job as a PT aide, requiring her to be on her feet and requires her to have her range of motion. And she just can't take much time off of work. And so even though ideally this patient would undergo a fusion, as would be supported by the literature, we decided to perform an L2 to S1 MIS midline sparing laminectomy. This helped her achieve her goals. Her symptoms were 80% better. She was able to start her job. About a year out, she has some increased numbness in her feet. She's overall satisfied. This case further helps illustrate how the current treatment algorithms may not fully represent the underserved. Maybe we should be looking at different things. And so future directions that we're currently researching, we are comparing patients excluded due to loss of follow-up to those included in studies. We're trying to get raw data from all these big landmark studies and take the patients who were excluded due to lack of follow-up and comparing them to the patients who were included in the study. Try to see if there's a difference between those two populations, especially in regards to the underserved. Now, obviously, we need to know follow-up to really see our outcomes, but at least make mention of what patients are excluded so we could at least state it as a limitation of the study and perhaps perform more focused studies down the road. In addition, we're handing out questionnaires to calculate the indirect cost of care that our patients incur. So we want to find out how long it took the patients to get to their appointment, how much work they had to miss, what their salary was, whether they had to have someone drive them, whether they had to have someone care for their kids, basically calculate the indirect costs of care. And once we know how much each appointment costs them, maybe we could help address those issues. And we're also evaluating the utility of MIS surgery in the underserved. Maybe the underserved tend to have a disproportionate benefit from MIS. Maybe it's disastrous, but I think we really need to evaluate it, and there aren't at least studies focusing on this population. And so In conclusion, the underserved are a unique population with unique needs. They are underrepresented in the literature. The current guidelines may not apply to them. And new treatment algorithms should be developed for this population. And so we could do better. We should do better. We will do better. I'd like to take the chance to, first off, thank Sig Bourbon. He's been a fabulous mentor to me, and he's really helped me have a soft landing at this institution and like guide me through my career. He's been a friend and a mentor. Thank you. I want to thank Ashraf Al-Naga, my partner. I mean, we sit in our office together and we come up with these ideas, and it's a lot of fun working with Ashraf, and he's with me for this mission. And also I want to thank Anthony DiGiorgio from Neurosurgery, who's also kind of joined us on this ride and drank the Kool-Aid and has been instrumental in all of our endeavors, as well as the rest of the UCSF spine team. And so here are my references. Thank you.
All right, thanks, Dr. Gendelberg. That was a lot of great information on an important problem. I see hand up from Dr. Stroud.
Thanks, Dr. Gendelberg. That was great. Because you've worked in a variety of different care environments, can you comment a little bit about the role of hospital and spine surgeon volume in access for these patients? Because I think there's some data in the spine literature that might be a driver of some of the outcome disparities that we see.
When you say volume, could you be more specific?
Yeah, there are a couple of papers in the CNL spine that suggest that hospitals that care, so they divide it into quintiles. Let's say the lowest volume spine hospitals and the lowest volume spine surgeons have significantly higher odds of mortality and complications. And it sounds like you've identified that some of these patients are traveling much further to get to places. So
yeah, and I mean it's more difficult. I mean, these populations from the get-go, they have, I didn't necessarily touch on some of the other social issues, but like homelessness, drug use, malnutrition, all those affect surgery. And kind of like how me and Dr. Al-Naga like to say, we have a lot of patients with pathology, but it's also patient selection. But at the end of the day, these patients also need surgery. And so it's kind of trying to find ways to operate on a complex population, but we can't operate on everyone just because they have a surgical indications. We need to also evaluate their social indications, and that definitely also affects volume.
David, thank you for addressing such an important topic, and thank you also for your commitment to underserved populations. It's really clear your passion for some of the disparities and equities we have in our healthcare system. One of the things you pointed out is that the literature oftentimes doesn't represent our underserved populations, and perhaps there ought to be differences in the benchmarks for some of our quality metrics. So things like reoperations, readmissions, infection rates. And right now, as you know, JBJS is actually requiring us to submit information on race and ethnicity because of the fact that the generalizability of our results might not apply to this population. So what should we do about reestablishing benchmarks and for what is an appropriate rate of 30-day, 90-day readmission? What's an appropriate rate of infection for specific cases?
Well, I think it's for each surgery and depends, it varies. Like if you're looking at the viability of a disc replacement, you do need those 10-year results. And unfortunately, the underserved may be excluded because you may not have follow-up for 10 years on them. But I think at the very least, you should also analyze the patients excluded from the study. So at least the people reading the literature could see who was excluded and who was included and maybe mention it in your limitations. There's no such thing as a perfect study, but I think a good study is able to shine light on its shortcomings and you're not going to get a lot of these people to give you the 10-year follow-up you need, but we do need that information. But we at least need to be aware that they're not included in those studies.
I also think the work that you and Anthony and Ash are doing is really going to be
Mhm.
important in terms of establishing benchmarks for this population.
Mhm.
So thanks for your work.
Dr. Gendelberg, thanks very much for shining a light on maybe a different way to think about the needs of the patient, and particularly people who have challenges with access. And you made a very compelling argument for how minimally invasive may be even more important consideration if the indications are right. And it strikes me, I wanted to ask you about systems a little bit. You know, we set up things like the Orthopaedic Institute, the Spine Center, trying to provide all of the services in one place. Idea being maybe make that access or to multiple things that are required, particularly in complex treatment like spinal conditions. And then you've got a construct like San Francisco General, which has a lot of things available, services available, but it's for a very contained, you know, San Francisco zip code. People from Central Valley can't come. Then San Jose Regional, where they might be coming from everywhere. And you've had exposure to all of these. I'm wondering if you can talk a little bit about the systems and how they work and what might be more or less beneficial in terms of treating patients with complex conditions like spinal conditions.
I think that's a fabulous, fabulous question. I mean, actually, the system that I think like gave me the most kind of insight was actually the system up at the University of Washington. When I was faculty up there, we accepted the underserved and the insured patients in the same clinic. I think that and we also had a lot of the services available, and we just used them as needed for the patients. I think there's also a certain psychological aspect when you go to a clinic where everyone over there is underserved versus where you have a mix of patients. It's in some ways, I almost look at it as like the school system. You always have the argument of whether do you mix the students from like better socioeconomic status with those from underserved communities to kind of bring everyone up, or whether you separate them. And I think you need to have multiple sites for access of care, but I'm not sure if you should have clinics designated only for each population. I think you could combine the two pretty harmoniously.
Specialized versus generalized spine center versus.
So I definitely think a specialized spine center makes sense because spine patients have unique needs that other specialties may not have. And I think when you have a spine center, I run my clinic with Dr. Nagao and Dr. Del Rosario, and it's a good adjunct to my clinic. And so if I see a patient that I think needs an injection, instead of bringing that patient back for another appointment, I'm able to ask them to see them right then and there. And that helps decrease the number of visits the patient has, makes their time more efficient, and overall is more beneficial.
Thank you for your talk. This concept of surgical versus social indications has been sort of bandied around for a long time, but in a quiet way. And recently, at one of our conferences, I quoted Heinz Wagner, who said, "Sophisticated operations for sophisticated patients," because I worry not only about the access part, but I worry about the after surgery part. And can a patient handle the recovery? And I was challenged by one of the members in the conference at an ethical level. So how do you reconcile this issue? Because if you bring in social indications, you're likely to increase exclusion of the very population you're trying to include. How do you manage that when you approach these patients?
So, I mean, the first rule of medicine is do no harm. And so with some of these patients, if they're living on the street and they're actively taking drugs, I would be harming them by doing surgery. But I think trying to address those concerns, or possibly less is more. kind of maybe do a small correction, and knowing that they have a higher rate of a second surgery in a few years down the line versus doing a large procedure that will knock them out for 5 months. And I don't see it as excluding that population, but you're just tailoring your treatment to that patient's specific needs.
Yeah, no, David, thank you so much for, first of all, being an awesome partner and for a wonderful talk. I think it's Dr. Diab, you sort of that question, it's something that we all sort of think about. I think the approach that we tend to take also is just because we're not offering someone surgery immediately doesn't mean that they're not getting care, right? And so non-surgical care is still care. And so a lot of times these patients are followed up through our clinic. And if we can get to a point where we, where surgery makes sense, then we cross that bridge at that time. But it's not a simple, we just don't see it as a simple binary yes or no. Yeah.
Yeah, so I share a clinic with these two guys, and this is near and dear to my heart. And kind of to address your comment there, Dr. Diab, one of the things that David had suggested to me, I think recently, is to do something like a tumor board for these patients. So I don't do tumor boards. So Rosie, if you're still here, Dr. Zimbel, correct me if I'm wrong, but basically these are very complex issues. We don't have good data. So we get a bunch of smart people in a room and say, okay, guys, as a group, in an unbiased fashion as possible, what should we do for this person? You can make a very strong argument, I think, that we should do the same thing for complex social patients who need complex surgery. I think now to actually do that would be difficult, but it was David's suggestion initially, and I thought it would be a great solution to that problem. Because I have these same ethical dilemmas every day. You see someone in your clinic and you're like, oh boy, this is a complication waiting to happen, but so is doing nothing.
Great. So I think we'll probably wrap up there. But again, thank you so much for coming to present, and really appreciate your insight.
Thank you.